Thank you so much. It's a pleasure to be here, and would like to thank the organizing committee and the Gilead for sponsoring this talk. I will talk about some of the evidence of benefits from early treatment for invasive fungal infection. Maybe I will allude to some work that was done on the diagnostic accuracy of some of the diagnostic tools, and also we'll discuss some of the comparative studies among different antifungals. So this talk is sponsored by Gilead. I wanted to start with this slide. So just wanted to highlight that data unfortunately from our area when it comes to invasive fungal infection is very limited. This is one of the poster published a few years ago, and just to highlight the burden of the invasive or serious fungal infection. Although this may be underestimated, it's similar to other parts of the world where candidemia, invasive aspergillosis, bronchopulmonary aspergillosis represent the main type of serious infection from invasive fungal infections. I think fungal pathogens came to focus with the advances and with also for the immunocompromised patient. This is the type of population that made this pathogens are important pathogens when it's come to morbidity and mortality for our patients. And I think this risk stratification, I'm sure every ID physician and hematologist or practicing physician with this type of population understand that there are different categories for patients when it comes for risk of infection from fungal pathogens. If you look here, for example, in this scheme, that's high-risk patients such as acute myeloid leukemia, allogeneic bone marrow transplant, liver, heart, and lung transplantation represent a major risk when it comes to fungal pathogen. In some of the population, for example, the allogeneic bone marrow transplantation risk of invasive aspergillosis is up to 15 to 20% in some centers. Patients with the intermediate risk, such as ALL, HIV patients, COPD and lymphoma, patients with the lower risk, such as autologous transplant, Hodgkin lymphoma, CLL, etc. I'm not going to go into details on this, but this is just to show you that the risk of infection could be quite different, or the epidemiology of these fungal infection, the type of fungal infection, the risk of resistance could be quite different when it comes to the host factors and the underlying immunocompromising condition. And I think several work has been done on the best strategy to treat patients with fungal infections. Probably you heard about the prophylaxis strategy. So this is giving antifungal treatment for a patient without sign and symptoms of fungal disease. For example, azole has been used for quite some time in patients with allogeneic or bone marrow transplantation, and it's actually improved survival in this population. So a well-known strategy with a very good evidence to improve patients' outcome. Also, you heard about the preemptive strategy, which is giving antifungal for a patient relying on a certain diagnostic tool that will detect the disease early. However, there is a huge unmet need when it comes to diagnostic tool to identify fungal disease. That's why this strategy is still debatable. Also, the empiric approach, which is giving antifungal therapy to a patient with a symptom and signs suggestive fungal disease, however, without microbiological documentation. And then the last one, which is the targeted therapy, which treating patients with a confirmed fungal pathogen. So let me talk about the diagnosis of invasive fungal infection. And I think because to use one of these strategies to treat fungal disease or invasive fungal infection, I think you need to understand a little bit about the diagnostic tool used for invasive fungal disease. And I think there are major unmet needs, as I mentioned. The gold standard for invasive fungal infection disease diagnosis still the culture. And unfortunately, the culture is quite not sensitive. For example, bloodstream infection with Candida has sensitivity only 50%. So there is a huge problems on relying on invasive fungal disease using these diagnostic tools. These are just examples. This is not an exhaustive list of some of the diagnostic tools used to diagnose fungal disease. Galactomannan, for example, for invasive aspergillosis. Beta-D-glucan for patient with the Candida. It can be also helpful for PCP. Fungal PCR. There is fungal PCR for invasive aspergillosis and for Candida. However, most of these tests either not sensitive enough or not specific. You cannot rely on them. And some of these tests does not have a standard. And probably another limitation is the cost and the availability of this resource in many hospitals. I'll just give you one example of the complexity of the issue. Although galactomannan is an antigen that's used for quite some time for patients to diagnose invasive aspergillosis, this is a meta-analysis done on a large number of patients using a galactomannan antigen to diagnose patients with invasive aspergillosis in immunocompromised population. You can see that the cutoff is quite challenging of the galactomannan to diagnose invasive aspergillosis. If you move this cutoff, for example, from 0.5 to 1, the sensitivity will change. The sensitivity will go down, and the specificity will improve. So it's a trade-off between the two. But it's just to highlight that the diagnosis of fungal infection using these methods is not straightforward. It requires a lot of knowledge from the practicing physician before considering treatment based on these tests. Another example, for example, we always say the galactomannan from the bronchoalveolar lavage fluid is quite helpful, is the method of choice to diagnose invasive aspergillosis in patients with a BMT. This is a study done on a patient, on a galactomannan use for a BAL fluid sample. If you look at this table here, just moving the cutoff between 0.5 and 4 change the sensitivity and specificity quite a lot. If you use a cutoff 0.5, the sensitivity is very good. However, you will significant number of patients will undergo treatment, will undergo unnecessary extra images where your diagnosis is false positive. Where if you move the cutoff, for example, to 3, you will have 100% specificity, but you will lack sensitivity, so you will miss a lot of patients with invasive aspergillosis. This is just to add to the complexity of using diagnostic tools for management of patients with invasive aspergillosis. In conclusion, this is my conclusions when it comes to using diagnostic tool for invasive aspergillosis. The clinical science, as we discussed, is not specific. The non-culture based are essential. Most of centers are using these tests. However, clinician must understand the pre-test likelihood of invasive fungal disease and the test performance. You need to know the test performance of each of these diagnostic tools and the pre-test probability from your clinical assessment. Just wanted to highlight that there are no tests that showed that it will reduce mortality or improve your survival in patient population. And if you look at the survival in patients with invasive fungal infection, it was only improved with the development of antifungals. That's how we improved survival in these patient population, and that's why I think this talk and discussing how to about the importance of early start and what to start, it's really important. So in general, I will talk about, maybe quickly run through some of the evidence that support the impact of timing of antifungal treatment on patient mortality. These data done, that's association between early treatment of antifungal with mortality in patient with Candida bloodstream infection. If you look at the bar chart on the right side, and you see the mortality risk in each category before blood sample taken for patient who receive antifungal within 24 hours or patient receive antifungal treatment after the 24 hours. You can see that mortality almost double between patients who were started on the antifungal before even the blood sample taken, and those patients who waited until more than 24 hours. This is another example also, Candida bloodstream infection, 121 patients. The empiric antifungal therapy has an odds ratio of 0.36, so almost 65% reduction of mortality or 28-day mortalities compared to those patients who received a late antifungal. Also, it was quite interesting to highlight. If you look at this again chart here. Do I have pointer here? Okay. The patients who received the antifungal beyond 120 days, so after 5 days of considering invasive fungal infection, as almost their mortality was 50%. Patients who received no antifungal treatment, their mortality was 43%. There was those patients who received the antifungal therapy beyond 5 days as if they received no treatment. Another study for for patient with the candidemia, basically showing the same thing, that the risk of infection risk of mortality significantly increase when patients are delayed to more than 3 days of starting antifungal therapy. This is another study that classified the period, which is the incubation period, so the period from the blood sampling until the culture come positive, and then the provider notification period, so from the culture positive until the provider notified, and then the antifungal treatment, which is after the provider notification. And what was interesting, look at the incubation period or the time to positivity of the fungal culture. The median was 32 hours. This is quite long. So beyond almost a day and a half to have a positive culture. This is the median. To have so 50% have their Candida positive after a day and a half. This is quite prolonged when it comes to impact on mortality. And what was interesting, that this time to positivity was correlated with the mortality. So still, I think most of the physicians still relying on the positive culture to start treatment. However, if you look at the evidence I presented, that's waiting until the positive culture, especially if you are considering Candida bloodstream infection, risk of death is quite high. Now I'll talk maybe about specific antifungal and risk of mortality for a specific disease. You heard about mucormycosis. This is a disease quite important, especially in neutropenic patients, patient multiple immunosuppression. This study was done on the impact of early treatment or the timing of treatment of amphotericin B and association with mortality for patient with mucormycosis. All patients here had a mucormycosis. All of them received amphotericin B, and they compared the early treatment versus delayed treatment with the amphotericin. And there was significant difference when it comes in terms of survival. This is a very difficult disease to diagnose, and at the same time, this is a disease that requires urgent intervention, whether it's surgical intervention or starting amphotericin B early. The difference was quite high, almost twofold risk of difference of risk of death from for those patients delayed antifungal amphotericin B treatment. This is a study done in Japan. It's quite interesting study that it's a retrospective study. They looked all patients who had septic shock and at the same time received amphotericin B. Of course, if you look at the patient population, most of these patients were immunocompromised patients, so received amphotericin B for a reason. And they compared the early start of the amphotericin versus delayed start just for treatment of septic shock. There was no significance in survival, which could be related to the small sample size. However, if you look at the recovery from septic shock, there was significant difference. Patients who received early amphotericin B, the median day of cessation of the septic shock was around 4 days versus 12 days in the patient delayed with the delayed start of the amphotericin B. This was also adjusted with the using propensity score matching. So it was quite sophisticated analysis that show starting amphotericin B early for a patient with septic shock in an immunocompromised patient could help in quicker recovery. So I think in the next few slides I'll talk about the antifungal treatment, maybe specific antifungal treatment in empiric setting, and just so empiric setting. So patient who do not have or patient with the sign and symptoms of fungal disease or suspected to have fungal disease before the culture documentation or using a diagnostic tool. Again, for candida bloodstream infection, you can see that the mortality is quite different between patients who received the antifungal treatment as an empiric therapy, less than 12 hours versus those patients received the antifungal therapy beyond 48 hours. And in the multivariable analysis, you can see that the delay in antifungal treatment had an odds ratio, adjusted odds ratio of death of 2. So just delaying the antifungal was an independent risk of death in this population. This is a landmark trial. This is an old trial published in 1999. It's a landmark trial now talking about specific antifungal. Compared the conventional amphotericin B versus liposomal amphotericin B in patient with persistent fever and neutropenia. So again, using this antifungal treatment empirically for patients with a febrile neutropenia. Patient population included here, mainly patients with hematological malignancy. All these patients had a febrile neutropenia, neutropenic fever, and received IV and received broad spectrum antibiotic for 5 days with no improvement, and included in this study. The study compared those two type or two different formulation of antifungal, and the difference when it comes to the overall success was not significant. 50% in the empiric liposomal amphotericin B versus 49.4 conventional amphotericin. However, I think it's important finding from this study when it comes to the infusion-related reaction and nephrotoxicity associated with the conventional amphotericin B. You can see here that there was significant difference almost in all parameters when it comes to renal failure, infusion-related reactions, it was fever, chills, electrolyte disturbance, etc. So this led to the approval of liposomal amphotericin B for use in neutropenic fever compared to the conventional amphotericin B. I'm not sure if any other centers maybe we use liposomal amphotericin B, but maybe I don't know if others still have experience or you still using the conventional amphotericin B. The second trial, again, for empirical treatment for febrile neutropenia patients. Again, all patients included here had a neutropenic fever treated with broad spectrum antibiotics. So a similar design, comparing amphotericin against voriconazole, non-inferiority trial, and the non-inferiority margin was 10. And the result here, if you look at the success, Empiric voriconazole was 26% success versus 30% in the liposomal amphotericin B. The non-inferiority margin, the confidence interval, you can see minus 10.6 to 1.6. So the point estimate fell outside or the confidence interval fell outside the non-inferiority margin, and that's why voriconazole was inferior. It did not meet the non-inferiority criteria when it's compared to the amphotericin B in management or of empiric febrile neutropenia treatment. However, guidelines still recommend voriconazole as a second line after the amphotericin and echinocandins. We consider it in certain cases, such as when there is a high suspicion, for example, of invasive aspergillosis, but it's not the first line. And was not approved or it not meet the non-inferiority margin in this trial. If you look at the side effect, as expected, liposomal amphotericin had more infusion-related action and more renal dysfunction. However, this was up to 1.5 from the baseline creatinine. If you look at the baseline increasing to 2 of the baseline creatinine, there was similar result of the voriconazole versus amphotericin B. When it comes to side effects, again, when it comes to abnormal vision, as you know, this is well known with the voriconazole, and this was much higher reported in a patient received the voriconazole. Last trial, comparison of caspofungin now with the liposomal amphotericin B for management of the same thing. Very similar design, very similar also patient population. Non-inferiority trial comparing the caspofungin versus amphotericin B, and you can see in the right side in the composite primary endpoint in this forest plot, you can see the overall response or the success was similar between the two groups, and caspofungin was non-inferior to amphotericin. This has led to the approval of the caspofungin, and now echinocandin used routinely as empiric treatment for management of patients with the febrile neutropenia. Again, caspofungin has much less infusion-related reaction, much less increase in serum creatinine compared to the liposomal amphotericin B. That's why both of these intervention, both these antifungal treatments are recommended as a first line in patient with the febrile neutropenia. I think in summary, rapid diagnosis of invasive fungal infection is challenging. It has a long turnaround time, and definitive diagnosis, identifying species, identifying resistance is not always possible. Multiple retrospective studies and design showed there is a very clear correlation between mortality and delay in starting antifungal treatment. Patient with a septic shock who received amphotericin, starting the amphotericin early rather than late, led to quicker recovery from septic shock. When invasive fungal infection is suspected, but the diagnosis is not possible, you need to consider antifungal with the best spectrum of activity. Liposomal amphotericin B is first line treatment for several rare mold and rare yeast infection, as well the drug of choice for mucormycosis. And again, treatment delay in patients with invasive fungal infection can increase the risk of mortality. Thank you so much.